Yeah, good evening. Today amongst us, Dr. Sudipto Mukherjee, a consultant critical care medicine of Tata Medical Center, Kolkata. Welcome to all the doctor participant. Requesting all, if you have any query or question, please post in the chat box. Doctor will surely answer it post the session. So I would like to hand over the session to Dr. Mukherjee. Please hand over.
Good evening, everybody, and welcome to today's session of Sepsis Update organized by CIPLA. I'd like to thank them for organizing such an important and relevant topic of our day-to-day practice. Myself, Dr. Sudipto Mukherjee, I work as a critical care consultant in Tata Medical Center. Sepsis is one of my areas of interest, so I try to stay updated, and I think out of more than 50 to 60% cases, if not more, in any ICU is related to sepsis. So all the doctors who are working in intensive care or in the any hospital should know about sepsis. So the core area that I will try to cover is the definition and diagnosis and how the concept of sepsis has been evolved over the last few years. Because with the understanding of the pathophysiology and the underlying challenges in sepsis, our management has also been modified. We look at the initial resuscitation in terms of fluid, pressures, and steroid, how we can optimize our antibiotics and biomarker. Few words about ventilator, though there is no new changes or for ventilation. And then look at the other rescue therapies that is currently available in sepsis management. So if you go to the past, sepsis was first documented 2,700 years ago in Homer's poem. It was derived from the Greek word called sepo, which means I wrote. And eventually, with time, presently it means decomposition or decay. In the subsequent years, it was used in the work of Hippocrates and Galen in later centuries. And in the year 1800, for the first time in germ theory of disease, we have identified that sepsis originated from harmful microorganism. That means first time we have recognized that there is a microbacteria which is related to the development of sepsis. In terms of pathophysiology, there are some other significant developments happened in the 19th century. And Hugo Scott Muller, he mentioned that sepsis is present if there is a focus that has developed from which a pathogenic bacteria either constantly or periodically invade the bloodstream in such a way that this causes a subjective and objective symptoms. So what we have mentioned that the bacteria is the pathogenic, the etiology of the sepsis. It is causing a local infection to begin with, then it's spreading to the body, other parts of the body, leading to symptoms, different subjective and objective symptoms. First definition of sepsis was given in 1991, and the journey of surviving sepsis guideline for the management of sepsis started from 2004. Now, why we are discussing sepsis? It's a huge global burden. It is one of the major cause of morbidity and mortality in critically ill patients. The numbers is very difficult to ascertain. Why? Because it's difficult to measure the attributable cause of mortality related to sepsis. The global epidemiological study shows the burden is more than 30 million and nearly 6 million deaths annually. If you look at the data in 2017, nearly 50 million cases and 11 million sepsis-related death was documented, which accounts for nearly 20% of the all global death, which is a significant number. And data from the Surviving Sepsis campaign in 2012 shown that in Europe there is a 41% death compared to 28% death in the United States. But this difference is not significant when you adjust it for the disease severity. That means if the patient has a multiple organ failure, severely sick, on high inotrope, has a higher chance of death compared to a patient with a sepsis or maybe with a single organ failure. So once we adjusted this difference, the mortality was reasonably same in all the European countries, all the Western countries, both Europe and USA. But once it is true that sepsis causes significant poor outcome and high chance of death, but it is also true that with our improvement in the management over years, the outcome has improved. This is a publication in 2014 and the data is from Australia and New Zealand. They look at the outcome of more than 1 lakh critically ill patients and compare the mortality of sepsis in relation to time. And they have found the mortality has decreased significantly from around 35-40% in the year 2000 to around 20% in the year 2012. That means even though there is no significant improvement in the or innovation in terms of antibiotics, but as we have understood sepsis better, as we have managed the initial resuscitation, other hemodynamics and organ supports better, there is a significant improvement in outcome in terms of mortality. So if we go back to the first definition of sepsis, which is from sepsis 1, it was based on the SIRS criteria. So by definition, patient have a systemic response to infection, which is called SIRS. And if patient has 2 or more criteria, like temperature more than 38 or 36 less than 36, heart rate more than 90, respiratory rate more than 20 or PCO2 less than 32 or WC count more than 12,000 or less than 4,000 or more than 10% immature bland form. So it indicates that there is an infection which is causing systemic inflammatory response syndrome. And we try to define it as a sepsis. And when there is an associated organ dysfunction or hypotension or evidence of hypotension like lactic acidosis, oliguria, acute alteration in mental status, we define it as a severe sepsis. And severe sepsis-induced hypotension that is not responding only with fluid resuscitation and causing inadequate tissue perfusion leading to requirement of vasopressors is called septic shock. But there are some lacunas in it because there are multiple other things which present as a SIRS like trauma, pancreatitis, burn, and it is very difficult to differentiate them from sepsis if you follow this SIRS criteria. Also in terms of the overall prognosis, it is very difficult to prognosticate patients on the basis of SIRS criteria. So I move to the sepsis 2 guidelines, which along with the suspected or documented infection, they try to streamline the diagnostic criteria into under different headings. Like general parameters means these are basically SIRS criteria. Inflammatory parameters means WBC count, procalcitonin and CRP. Hemodynamic parameters in terms of the capillary refilling and the blood pressure requirement of vasopressors. Organ dysfunction in terms of the organ failure, like the patient is hypoxic requiring oxygen, whether the patient has a liver dysfunction in terms of high bilirubin, hematological dysfunction in terms of low platelet count, or renal failure, or hypotension requiring vasopressor support. And then tissue perfusion parameters in terms of capillary refill time and lactate. But what it makes the whole thing very complicated. Sir Osler Williams has mentioned this in the year 1904 that except on a very few occasions, the patient appeared to die from the body's response to infection rather than from it. And from this understanding, in the last sepsis guidelines or definition, that is the sepsis 3 definition, for the first time we recognize immune dysfunction or dysregulated host response to infection as a major cause of poor outcome related to sepsis. We define sepsis as a life-threatening organ dysfunction. So first time we mentioned when you talk about sepsis, we are basically talking about organ dysfunction caused by a dysregulated host response to infection. So infection may not be severe, bacteria may be very sensitive, but if the immune response is dysregulated and there is a hyperimmune response, that may cause organ dysfunction and poor outcome. And in the early part of sepsis, hyperimmune response is the more prevalent. When you talk about septic shock, it says that the patients are more sick with profound features of circulatory, cellular, and metabolic abnormality, which has a higher chance of death. So if the sepsis has a mortality around 10%, septic shock has a mortality as high as 40%. And this is because there is inadequate tissue perfusion. And that has been measured in terms of lactate, capillary refilling time, and in terms of intervention, we need vasopressors and fluid resuscitation to have a better outcome. We also try to use simple scoring system to screen sepsis. And the score we have used is called QSOFA or Quick SOFA. It has basic 3 parameters like respiratory rate, altered mentation, and systolic blood pressure. But what we have found though it is very specific, the sensitivity is very, very poor. So that's a big concern to be used as a screening tool. So this has not been accepted. So we are more comfortable for monitoring or more scientific to monitor sepsis is by SOFA score or sequential organ failure assessment. As we define sepsis by an organ failure, it is better to objectify that organ failure on the basis of a scoring. And the advantage of SOFA, QSOFA or SOFA score is that We can do organ specific SOFA, that we can monitor a specific organ function with time course. Or also we can define that if there is an increase in SOFA score by 2, there is a worsening organ failure, need specific intervention or specific assessment for that. As I mentioned, QSOFA has been used as a screening tool. It has been used as a multiple meta-analysis. And eventually, one has 38 studies, one has 121 studies, and one has 10 studies. And what they have concluded, that the search criteria, and it has been compared with the search criteria. They have shown that the search criteria has sensitivity around 88%. QSOFA is more specific, as I mentioned, 74%, but compared to search, but less sensitive. It is only 50%. So we cannot use a tool for screening purpose if it has a poor sensitivity. And as a predictor of hospital mortality, the area under the curve prefers QSOFA compared to search, because eventually QSOFA includes organ function, and we mentioned that with a worsening organ function, patient has a higher mortality. Now we'll come to the intervention. So whenever this type of patient come to the emergency department, our initial target is to do objective resuscitation in a goal-directed manner to save the organ failure. And along with that, we'll start definitive management of sepsis in terms of cultures, antibiotics, and other needs. So if you look at the first surviving sepsis guideline 2012, we understand, even at time, we understand the need for early intervention. So we divide those interventions in a time-bound manner. So you mentioned that there are some interventions need to be completed within 3 hours, and some interventions may have little more laxity and can be completed within 6 hours. And it includes lactate measurement, sending blood culture with an antibiotics, appropriate fluid resuscitation with a crystalloid if the patient is hypotensive. Within 6 hours, we are suggesting for a vasopressor support. The patient has a persistent hypotension, probably measurement of CBP, SCVO2, and remeasure lactate as a marker of tissue perfusion. And in this recommendation, we have strongly suggested for SCVO2 as a measurement of tissue hypoperfusion. But what happened when you monitor the outcome of these patients compared to the time of resuscitation? It has been done in nearly 50,000 patients over 149 hospitals. We found that there is a significant increase in risk-adjusted mortality with time. That means even if I'm completing all those interventions within 3 hours, if those are done within 1 hour, there is a higher chance of survival compared to the 3 hour. So putting a 3 hour capping or a 6 hour capping is not that logical, because within every hour delay, even within that stipulated time period, patient may have a poor outcome or high mortality. So in the 2018 surviving sepsis guideline, incorporate all those interventions within a 1 hour bundle. And the interventions are reasonably same, except that we have taken off SCVO2 and measurement of CBP, because they are complicated and getting a definitive measurement is very, very challenging. SCVO2 is not possible as we are moved away from the PA catheter. So what are the interventions? Measurement of lactate, send culture, start broad spectrum antibiotic, start fluid resuscitation, and the change is that apply vasopressor if the patient is hypotensive during or after fluid resuscitation. The MAP is less than 65. That means it is not fluid resuscitation followed by vasopressor. It is fluid resuscitation along with vasopressor. We should start vasopressors early to maintain optimal perfusion pressure. And regarding the fluid resuscitation, the recommendation they have mentioned is 30 ml per kg of body weight. Now, from where they get this 30 ml per kg? They have looked into the ER patient's data, and they found that only even after this recommendation of 30 ml per kg body weight, only 50% of these patients receive 30 ml per kg. And overall mortality in this subgroup of patients was 70%, 17%, and in the shock group it is around 20%. And which are the patients who has not received 30 ml per kg? These are elderly, male, obese, or patient who has a renal failure, end-stage renal disease, or heart failure, or documented volume overload. In this patient, we are little hesitant to provide 30 ml per kg of body initial fluid resuscitation. 30 ml may not be the targeted number, but the understanding is that even who patient has a heart failure, past history of cardiac dysfunction, or a end-stage renal disease, once they're septic, into coming into the emergency with septic shock, they need optimal fluid resuscitation in early phase. Failure to meet that may cause higher odds of mortality, prolonged hypotension, and increased ICU stay. And the effect of fluid resuscitation usually start plateauing between 35 to 45 ml. That's why the recommendation is beyond 30 ml per kg, we need to give fluid in a guided manner, either by an echocardiography or other advanced hemodynamic monitor. Now, as I was mentioning, how this 30 ml per kg has come. When these are the three very important studies that have been published very recently. These are called ARISE trial, PROCESS trial, and PROMISE trial. And they look at the initial resuscitation, fluid resuscitation in critically ill patient coming to the emergency. They also look at the need for pulmonary artery catheter and measurement of SCVO2. But when they look at the fluid that the patient has received in the initial first 24 hours, the initial resuscitation, they found that it is around 30 ml per kg. From that, the Society of Cervical Sepsis guideline mentioned about this number. The next question will be whether to use colloid or crystalloid. Now this fight is basically over. The recommendation is to use crystalloid as the first line for fluid resuscitation. They suggest to use albumin in patients who receive large volume of crystalloid over using only crystalloid. The recommendation is not that strong. They recommend against using starch and against using gelatin. So in intensive care critical ill patient for surviving sepsis management, the use of starch and gelatin is out of the box, out of the equation. And this has been concluded on the basis of these multiple studies like Sepsis trial, Sepsinet trial, Chase trial. In all those studies, Christmas trial, Crystal trial, all these studies have been shown if you use crystalloid as a resuscitation fluid, the patient's outcome is better. What is the role of albumin in septic shock? As I mentioned, societies recommend that if you are requiring a large amount of fluid in a septic shock patient, you can consider to give albumin. It has been extrapolated from a study called Albios trial, where in the subgroup analysis, that means the target of the study was not to look at the albumin. It was an outcome data after the study. So obviously, this is not going to be adequately powered. The number of samples is not sufficient to conclude about this outcome. But what they have concluded, what they have found, they found that patient in septic shock who has an albumin less than 3 gram per dl. In this situation, if you resuscitate with 5% albumin, they have a better outcome compared to only crystalloid. And this is another meta-analysis which showed the patient with a sepsis with septic shock, when you with the resuscitation is done with a balanced salt solution along with albumin, the outcome is better in terms of reduced mortality. Even then, the data is not very strong and the studies are very heterogeneous. But what about normal saline and balanced salt solution? This fight is still on. Though the balanced salt solution is physiologically much better, because we know when you are using sepsis, we are using a large volume of fluid, crystalloids, and if you give a large volume normal saline, there will be hyperchloremia, there will be hypercholemic metabolic acidosis, and it can cause renal tubular injury. But the recommendation is still suggesting balanced salt crystalloid instead of normal saline for fluid resuscitation. As I mentioned, recommendation is weak with a low quality of evidence. Because there are multiple studies which are published recently with a very heterogeneous conclusion. The last large data which we have is called SMART trial or SALT-ED trial that has been suggested in favor of a balanced salt solution, specifically when you're using a large volume of fluid, both in ICU and also in a less sicker patient in the ward. Next question is, we understood that we are going to give fluid. How much fluid to give? This concept has developed long ago by Emmanuel Rivers. We all know that this is Rivers trial when he has guided us in terms of a goal-directed fluid therapy to our patients. So maybe the understanding is not appropriate in the present scenario, as he has mentioned is CVO2 or CVP, but the physiological understanding is still there. So you have to optimize the intravascular status, then you have to give an optimal blood pressure by a vasopressor, and even after that the tissue perfusion is inadequate, we have to increase cardiac output, either giving inotrope and also by giving blood transfusion. And as I mentioned, these are three main recent studies that have been included, and it shows that in our present clinical management, we are doing good enough even without measurement of SCVO2. So SCVO2 is presently out of our equation. But the physiological understanding of giving optimal fluid to maintain volume status of the patient, maintaining optimal blood pressure by giving a vasopressor, and increasing cardiac output either in terms of giving blood transfusion or giving an inotrope is still there. Another thing that has been changed recently is to understanding of the importance of early vasopressor. So the present recommendation is using norepinephrine as a first-line agent over other vasopressor as early as possible. For adults with septic shock who are on norepinephrine with inadequate MAP, which they suggest to adding vasopressin instead of escalating dose of noradrenaline. So the present practice or present recommendation is that when the noradrenaline requirement is around moderate, that is, if you go by hour dilution, it will be around 10 to 15 ml per hour by 4 milligram in 40 ml. Probably we should add vasopressin rather than increasing the dose to a supranormal level. The rationale is that vasopressin is going to act by a different receptor, V2 receptor, and probably it is going to give a better blood pressure compared to using only norepinephrine. For adults with septic shock with inadequate mean arterial pressure, despite norepinephrine and vasopressin, the next line of drug will be epinephrine. So as I mentioned, in terms of vasopressors, the recommendation use norepinephrine as a first line. Target MAP is 65. Consider invasive blood pressure monitoring if the patient is hemodynamically unstable. Next line will be vasopressin, followed by adrenaline. If the patient has a cardiac dysfunction and persistent evidence of hypoperfusion, despite adequate volume status and blood pressure, probably we need to add dovitamin or epinephrine. Now, in terms of the noradrenaline or vasopressors, so we have tried dopamine also in terms of the renal dose with the thought that it will improve renal perfusion. It shows to improve renal perfusion, but it does not improve outcome. It improves renal perfusion by causing renal vascular dilatation, but the outcome or in terms of overall patient outcome and mortality, and also in terms of renal dysfunction in critically ill septic patients, it does not show any benefit. So it is out of the practice. Low dose of dopamine for renal protection is not recommended. Now, when you compare dopamine along with norepinephrine in terms of vasopressors, this is called SOAP trial. It has been shown that the overall outcome in terms of the vasopressin and dopamine and norepinephrine is same, but dopamine causes a higher chance of arrhythmia, and it has because of its tachycardia, it causes tachycardia, and at the same time, the cardiac subgroup of shock patients, it causes increased mortality. So if in one subgroup we should not use dopamine is the cardiac one, because it will cause tachycardia, increase oxygen consumption, there will be oxygen demand supply mismatch with poor outcome. And even in different randomized controlled trials, it has been shown that early use of norepinephrine in septic shock resuscitation clearly has benefit over fluid resuscitation followed by noradrenaline. And it shows that when you use noradrenaline or vasopressors early, there is a decrease in the net fluid balance, lesser need for steroid, rapid improvement of hyperlactatemia with a better outcome in these patients. And the next is the VAST trial I've already mentioned. When you compare with vasopressin versus noradrenaline in septic shock patient, it shows if you add vasopressin in a less severe septic shock, when noradrenaline requirement is not very high, it can cause a 28-day and 90-day mortality benefit. That's why, as I mentioned, in a moderately septic shock patient, if the noradrenaline requirement is moderate, we should start vasopressin rather than delay it for a longer period. What about comparing between vasopressin and noradrenaline? This is called VANISH trial. When patient had tried to use vasopressin first compared to noradrenaline, look at the renal outcome, whether it favors better kidney outcome. And it's shown that among adults with septic shock, early use of vasopressin compared with norepinephrine did not improve renal failure-free days. Another intervention that has been considered is permissive hypotension, especially when you are dealing with an elderly patient. And in this trial, what they have done, they look at the vasopressor exposure and the 90-day mortality, and they target a lower blood pressure for the elderly population. But again, they have found patients with more than 65 years of age who are in septic shock or vasodilatory shock. Permissive hypotension compared with an usual standard care does not reduce long-term mortality or 90-day mortality. So practice is also out of equation. And this is another new vasopressor that will be in the market for clinical usage, which is called angiotensin 2. In studies in septic shock patients, it has shown that it is non-inferior to the noradrenaline. This is called ethiostral, and it will be very soon will be available for clinical usage. And the advantage is that it is going to be act to a different receptor. So in refractory shock, probably you can use it as an add-on over noradrenaline vasopressin and can have a better outcome. Next is the hydrocortisone. It was first promoted in Corticus trial that has shown that in septic shock patient there is a relative adrenal insufficiency. So if you add hydrocortisone as a stress dose, that is 50 milligram 4 times a day or 200 milligram per day, the resolution of shock is better or faster. But there is no mortality benefit. And in the next study, it is shown that along with hydrocortisone, can we add fludrocortisone? Just 1 second, please. Hello. Hello. Am I audible? Hello.
Yes, sir. You are audible.
Sorry for the interruption. Even in septic shock patient, we feel that why only hydrocortisone? Why? What about adding a mineralocorticoid like fludrocortisone? It has shown that if you add fludrocortisone along with hydrocortisone, with a dose of 50 microgram, the resolution of shock is better. But these are very soft data, and it has been shown only in a few studies, like as I mentioned, quick trigger safe trial. It has not been repeated in different other studies. But it is safe, you can practice it. And in terms of hydrocortisone, present recommendation is to give it as an infusion of 200 milligram over 24 hours. And when to taper it and stop it when the noradrenaline or vasopressors are off. What about the other adjuncts? So it was a very famous study of Merrick when they have used hydrocortisone, vitamin C and thiamine for the treatment of severe sepsis and septic shock, and it's shown there will be a significant, nearly 50% decrease in mortality. But again, this data has not been able to be repeated in other studies. It's shown that whatever the benefit that can be achieved from this combination is because of hydrocortisone by the mechanism I have already mentioned. Now, the use of vitamin C and thiamine in septic shock patients or severe septic patients is little controversial. Thiamine can be considered because in sepsis, the requirement of thiamine in the body increases, and if the patient has a thiamine deficiency, patient can cause a lactic acidosis. So thiamine can also be reasonable, but using a vitamin C in a high dose, like they have used 6 grams per day in a septic shock patient with a renal organ failure, like specifically there is a renal failure, chances of oxaluria is higher, that can cause worsening in the renal function. So it has not been a very standard of care or standard practice in critical care. In terms of lactate, it has been strongly emphasized to measure lactate and monitor lactate in septic patient, use it as a tissue perfusion marker. So the recommendation is that for adults suspected to have sepsis, we suggest measuring blood lactate. Sensitivity is around 60 to 80%, specificity is also around 80-85%. Pooled positive predicted likelihood ratio around 5, and negative likelihood ratio is 0.29. That means if it is there's a higher chance of sepsis, it's low probably it rule out the sepsis, specifically in terms of tissue hypoperfusion. And there is a strong association between the use of point of care lactate measurement and reduced mortality, because it can give you an indirect data in terms of tissue perfusion, and presence of an elevated or normal lactate level significantly increases or decreases the likelihood of sepsis and also the final outcome. So if patient is a high lactate, we resuscitate it. That then lactate is coming down, this patient is going to have a better outcome. And if someone is lactate is not coming down, that we mentioned, lactate clearance is suboptimal, probably they are going to have a poorer outcome. But lactate is not available in every hospital. Can we have a cheaper or easier option? This has been shown in this Andromeda shock trial. What they have done, they compare lactate with a peripheral tissue perfusion technique by capillary refilling time. And they measure capillary refill time and compare with normalization or decreasing lactate. That we take cutoff as a 20% decrease by 2 hours during the first 6 to 8 hour resuscitation. They found that in a tissue perfusion group is equally good compared to the lactate in terms of measurement or in terms of assessing final outcome. Even in the 90-day mortality is better in this tissue perfusion group compared to the lactate group. So at least the take-home message should be, if the lactate is not there, you can use capillary refilling time as a surrogate marker for tissue perfusion. Early antibiotic, I don't think need any emphasis because it's a very, very important step, and we all understand we have to give it as early as possible. First time, in an objective manner, it was promoted by Anand Kumar in his patient paper, which shown that in a patient who is in septic shock, every hour delay in antibiotic, appropriate antibiotic, the mortality increases by 6%. So probably it moved us or pushed us to use appropriate empirical antibiotic in our critical ill patients, specifically the patient is in septic shock. So present concept is you start with the broad spectrum antibiotic and gradually then de-escalate according to the culture sensitivity and patient's clinical response. But what happened because of that? There is a significant increase in the usage of broad spectrum antibiotics. So if a patient is coming to the Tata Medical Center with a septic shock, probably his initial antibiotic is meropenem and colistin and teicoplanin. And now in shock, it is still justified. What about if the patient is not in shock? They have found that if we focus on the initial assessment and even hold back using very broad spectrum antibiotic in patient who does not have shock, probably the outcome is not changed. So if the patient is in shock, this is the present recommendation. We should start empirical broad spectrum antibiotic early within 1 hour of recognition after sending appropriate culture. If the patient is not in shock and the sepsis possibility is little doubtful, then it is better to evaluate the patient, rapid assessment on comparing infective and non-infective cause, and we can hold back antibiotic for maybe up to 3 hours if the sepsis is not the possible cause. And at the end of 3 hours, if you are still not sure about sepsis, then we should start antibiotic. So in critical care, the standard statement is, it is if a patient admitted with an organ failure, it is sepsis unless proved otherwise. So if you have to hold back antibiotic, you have to have a very strong reason against it. And for antibiotics, we have to understand the PKPD of antibiotics to utilize it to its maximum. Presently, in the era of MDRO, and as no new antibiotics are coming, we have to choose antibiotic that has favorable PKPD in terms of the target organ. Like if the patient is pneumonia, the drug should concentrate better in the lung. If the patient is in urosepsis, it should better concentrate in the urine. And for that, we have to have an understanding in terms of the AUC of the area under the curve, above MIC or time, or the peak concentration of the MIC. What is the mechanism? Is it concentration dependent? It's a time dependent. Like if it's concentration dependent, like an amikacin, you give a single dose. If it's a time dependent, like a carbapenem, you give it as an infusion, either a prolonged infusion or sometimes an extended infusion over 24 hours. Next, biomarker. Even with all these clinical assessments, sometimes very, very challenging to diagnose sepsis, and also to diagnose or identify the recovery or improvement of sepsis in our patients. So sometimes the biomarkers can help. So biomarkers are molecules. Basically, they are present in the pathophysiology of the body in the sepsis. So most common is C-reactive protein and procalcitonin that has been utilized in our practice. But procalcitonin is definitely better in terms of the area under the curve, both sensitivity and specificity. And it has been shown in the meta-analysis. But for diagnosis of sepsis, procalcitonin does not have any significant role. So when the studies has compared procalcitonin in terms, even in a structured manner, in the Western countries, and try to identify infect bacterial and viral pneumonia, they've shown that it is better if you go by procalcitonin and get some advantage. But the main advantage that has been shown by procalcitonin is in terms of de-escalation. If you de-escalate antibiotic in a structured manner on the basis of procalcitonin, probably there will be a lesser amount of usage of antibiotics in the study group without any poor outcome. But the challenge is that these are data from the Western countries when the patients are not that sick. Only 50% patient was in shock, and mostly it is a pneumonia compared to the other organ of sepsis. There are multiple systemic review and meta-analysis which compares the procalcitonin-guided antibiotic de-escalation compared to the usual care, and they have shown that probably procalcitonin-guided therapy can decrease antibiotic usage by around 1 day if you are using prolonged antibiotic. That means we are using antibiotic for more than 7 days. Mostly what we do, this has been shown in both two meta-analyses. What we do usually consider procalcitonin negative or non-infective zone if it is decreased by 80% of its peak value or it is less than zero point 0.5. Now this cutoff of 0.5 in ICU is also very dubious. There are multiple other reasons of inflammation which can increase the interleukin 6, which eventually lead to increase in the procalcitonin. So for ICU critical or critically ill patient, should we take 0.5 as a cutoff or 1 as a cutoff? We do not have any definitive answer. But it is for sure that procalcitonin has a very significant prognostic value. That means if the patient is not improving and procalcitonin is persistently high, probably this patient has a poor outcome compared to the patients whose procalcitonin is coming down and there is a significant procalcitonin clearance. There are other markers also which is coming into the practice which may not need an extra test, but just some laboratory data that you have to collect. One of them is called mean diameter of the WBC. They have been used it for the neutrophil, monocyte and neutrophil, and they found it can guide us in terms of diagnosis of sepsis because this has a different impression. There are other novel biomarkers which are also coming like stream or proadrenomedulin, presepsin, and still they are at the research level. And how to interpret them, what should be the cutoff in septic patients is still lacking in clinical practice. But what we are looking probably is looking at the concept called biomarker signature. That means we'll send multiple biomarkers, it will give different value, and probably that from those values, a software or an AI will tell us this is the probability of sepsis in our patients, maybe in terms of 80%, 90%, and 70%. And accordingly, we have to decide a cutoff to start antibiotics in our patients. Now, what about rescue therapy? Rescue therapy means patient is septic, you're giving antibiotics, vasopressin, still the patient is not responding, there's a clinical deterioration. And as we have already understood, it is basically because of dysregulated immune response. So probably we can have some interventions that can act on the immune system to have control that hyperimmune response. So multiple interventions has been done, like a high volume hemobiofiltration, which is done in Ivory trial or Hycoris trial. Polymyxin the hemophil. What the idea is that when you're using high volume hemofiltration, all the cytokines that is present in the blood because of sepsis will be removed from the body. So the problem is that it removes both pro-inflammatory and anti-inflammatory cytokines. Along with that, there is a loss of antibiotics and significant electrolyte disbalance. So probably these are the reasons this study did not show any positive outcome. Next is polymyxin hemofiltration therapy. What they have done, they run the blood through a filter where the endotoxins are absorbed. But even then, there may be some small data which is positive, but overall this has not been recommended as a standard of care. And the third is called blood purification technique by cytosol, where the blood is run through a filter when all the cytokines from the range of 10 to 40 micron will be absorbed onto the filter, and it decrease the peak of cytokine surge and giving rise to better hemodynamics and lesser tissue damage. But again, maybe we can use it on a case-to-case basis, but there is no strong recommendation because the outcome, the number needed to treat is very, very high and the cost is significantly costly. Same thing is for IVIG. Except in a very limited scenario, there is no recommendation for use IVIG. Most of these studies are negative. So we should not forget about our best supportive care or the practicing good critical care in these patients. First tug beats, we are all aware. So optimized pre-resuscitation followed by early starting of nutrition and making those patients euvolumic or negative after the ensure adequate tissue perfusion. So the concept of deresuscitation is very, very important managing critically ill patients. Optimal analogous sedation so that we can wean these patients early. We have moved away from benzodiazepine group of drugs. Probably the choice of drugs are now propofol and dexmedetomidine. DVT prophylaxis, stress ulcer prophylaxis, keeping the head end up, glycemic control, optimal utilization of the lines, looking at the drugs and mobilization of the patients to prevent pressure ulcer. These are very standard of care in any ICU, and trust me, these are the things which can improve outcomes significantly rather than broad antibiotics. What about long-term outcome? Long-term outcome data is still very, very lacking. Most of it we are focusing on the initial recovery, initial outcome. Long-term outcome data is very limited. And we have some data in terms of the respiratory failure or ARDS patient for sepsis. It is not that much there. But what is important that it all depends what is the residual organ failure. because a lot of times this residual organ failure persists and these patients have to live on with that without any 100% recovery. For example, initially we thought that acute renal failure is a fully reversible cause, but we understood now that only 30% of this acute renal failure patient will reverse, 30% will have the residual damage, and 30% may proceed to a chronic renal failure in a chronic CKD status. By this, I like to conclude my presentation and I'll be happy to take questions. Thank you. I think I can take the question from the chat box. I will suggest all the attendee to please put your questions there. So first is how source control is important. Now source control is a very important step in sepsis, and that has been recognized long ago. Now if you do not remove the source uh, cause of sepsis in the body, no antibiotics, no fluid resuscitation or hemodynamic optimization is going to act. So if the source is a central line, you have to remove it. If the patient, it's a urinary catheter, we have to change it. If patient has an infected collection in the lung or in the abdominal cavity, we have to drain it. So that is very important and integral part of sepsis. We have to do it as early as possible. Purpose now, if there is any artificial joint or heart valve, I'm not sure about the joint, but having an artificial heart valve does not make a patient prone to sepsis. But which has other challenge in terms of destruction of the RBCs and all those things. Patient may have a chronic anemia in the subgroup, but it does not increase the chance of sepsis. But if the patient develop a endocarditis, prosthetic valve endocarditis, challenge is that the antibiotic does not work very well. There is very few antibiotics that works very well on a prosthetic valve, and one of them is rifampicin. So probably all the recommendations suggest to use rifampicin inclusive or rifampicin antibiotic that includes rifampicin for prosthetic heart valve endocarditis. What is the purpose of checking lactate? Now, lactate in the initial part of sepsis, lactate indicate tissue perfusion. Only the initial part for first 6 hours, maybe up to 12 hours at max, not beyond that. So purpose is to measure lactate, look at the status of the tissue perfusion, because sometimes patient may have a normal blood pressure along with high lactate that indicate the tissue perfusion is not optimal even when the patient has normal blood pressure. These are called cryptic shock. Lactate more than 4 has been recognized as a diagnostic criteria for shock. They need fluid resuscitation and you have to check lactate. That means the tissue perfusion is improved and the lactate is coming down. Once lactate starts coming down, probably it will be more reassuring sign that patient is improving. Now the difference between sepsis and severe sepsis has been taken off because of this terminology are very confusing. Now it's an infection and sepsis and septic shock. Infection means patient has a pathophysiological cause because of the bacteria, but there is no, or virus or fungus, but there is no organ failure. Once there is an infection along with organ failure, it becomes a sepsis. And if the patient has a sepsis with shock, requiring noradrenaline, not responding to fluid resuscitation, that becomes septic shock. Why it is important? Compared to infection, when patient moves to sepsis, mortality increases by 10% because of the organ failure. And if the patient is in shock, mortality can be as high as 40% because of this. So that's why it is important to identify this as early as possible and resuscitate them to its optimal level. These are all questions that we have here, and if anyone want to ask any question, he can unmute him and ask me.
Yeah, thank you, sir. I would like to tell the audience, if you have any question, you can write it out on the chat box or you can unmute and ask. I think, sir, there is no questions left. So
I think then we can close it.
yeah. Just I would like to thank Dr. Sudipta Mukherjee for a beautiful speech about the sepsis update, and all the attendees who have joined. I would like to thank Dr. Mukherjee. for this lovely session.
Thank you so
Thank you,
much
sir.
for organizing this.
Yeah, yeah,
Great to be with you all. Thank you.
yeah, yeah. Thank you, sir.